I still remember her eyes. It was a crazy day in the CVICU with monitors beeping, alarms ringing, nurses giving shift report to each other. But there stood Mrs. Thompson by her husband's bedside, wringing her hands, with a cold cup of coffee she never drank. He had suffered a heart attack the night before at the bowling alley. But thanks to quick EMS response, ER physician being on his game, and the cath lab doing their expertise, he survived. But she sat there at his bedside with worry etched on her face. I've been married to him for 51 years. Something isn't right. Isn't there anything you can do? Well, we thought he'd made it through just fine. His heart monitor was sinus rhythm, his vital signs were stable, but he wasn't fine, and she knew it. We made our notes in his chart, we nodded our heads and listened, and she stood there worried. We didn't notice the subtle signs of him changing, which she felt it in her gut. Several hours later, the alarms are screaming ventricular tachycardia from his room. Healthcare providers know what that is, but for the rest of you, that's an emergency. We pull the crash cart in there. We start working the code as she's watching complete strangers do chest compressions on the man she'd been married to for over half a century. He didn't survive. And it's not because we didn't have the skill. We did. We did this, unfortunately, on a regular basis. But it was because we didn't listen. I've been in healthcare a very, very long time. I went into nursing school at 17 years old, right out of high school. I've been in critical care nurse and nursing education for all of my career, and a patient safety advocate. There's one thing I've learned. If we don't listen, we don't act, and that can cost us our patients' lives. So we heard a little bit about this today. Medical error is the third leading cause of death. Now, I was a nurse for several decades before I learned that fact. And I thought, why don't we talk about this? I was stunned, honestly. You know, it has been a long time since this has been on the radar of healthcare providers, but again, we don't talk about it. I remember a nursing orientation I went 2 years ago where Dennis Quaid, who made the movie Chasing Zero, talked about his twins and talked about how they nearly died in the ICU because of a medical mistake. So it's in our literature, it's in our realm, but again, it's not a part of the conversation that we have. The Joint Commission has told us for years now that communication breakdown is responsible for 70% of patient harm events. And just this year, the ECRI organization several months ago identified the number one patient concern for safety in 2025 is the risk of dismissing patient, family, and caregiver concerns. I want to say to you today that I believe listening is a critical and clinical intervention, and it can make the difference from our patients. Helen's story with her son and Mrs. Thompson's story tell us that we need a structure to be able to wrap our arms around how we can do this better. So I created the CARE framework because care should be wrapped in healthcare, right? Do we all agree on that? Connect to the concern, activate real-time feedback, respond with urgency, and ensure the loop is closed. So connect to the concern. I'm going to tell you another story, a true story, about Christopher. I actually met Christopher's father at the Patient Safety Convention last September, who told me his story. And as a mother of 7 children, I can't even imagine. So Christopher, a son and the father of 2 beautiful girls, was driving home from seeing his friends on a warm, balmy South Florida night when he was tragically T-boned. He suffered a traumatic brain injury and had to be taken in for a craniotomy, but he survived. So on day 18, he'd been progressing. Let me start with there. He was recognizing his family. He was following simple commands, and he was able to be weaned off the ventilator and now just breathing through his trach tube. But on the afternoon of day 18, his parents came to visit. His mom was a critical care nurse and his father a respiratory therapist. When they stepped into his room, they froze. His mom said, "He's breathing doesn't sound right to me." And his father said, "You're right, and his oxygen levels are low." The respiratory therapist came in the room and shrugged and said, "He's been breathing like that all day. I've turned up his oxygen a little bit. He'll be okay." But he wasn't. His parents asked to get an arterial blood gas test, which showed that Christopher had been struggling to breathe for 12 hours. Several hours later, he coded, and he did not survive. On autopsy, they found that Christopher's trachea had been torn, and they think it was in the morning when the chest x-ray plate was put behind him and jostled him and tore his trachea. But we didn't listen. We didn't connect to the family's concern. I want you to think about this just for a minute and close your eyes, if you would. What would you say if you were a patient or family member and you were scared or concerned? Now think about you said that to the person next to you and it was ignored. Imagine how that might feel. This is why feedback tools are so critical and so important. And I want to propose to you today that we have these already, but they're getting better. And that's why I think AI has a perfect place in healthcare right now. So we have QR codes right there. We have bedside tablets. We have text surveys that patients can fill out and their families. When these can go right to the person that needs to help them when it's that time. When they say things like, "I need help, something's wrong, I'm scared," we actually hear them and we respond. We've talked a lot about these concepts today already. And thank you again for the cuss words. I added a third one in there to make it the real cuss words. And again, these aren't the ones you have to bleep out, right? So you can teach these to your patients and their families and your staff. When patients use these words, it's an alert to us that something is wrong and they need our attention. They're pretty powerful, or they should be. The care framework, the next part, activate. Activate real-time feedback. That doesn't mean 2 or 3 weeks later, right, when we get those surveys, but now when it matters. So I'll share with you this story that gives you a glimpse of what I felt like when I was scared and vulnerable at a time in my life. My sister and I took our 88-year-old grandma to France. We wanted to experience our family heritage and share this with her. Well, it was a long flight and we were exhausted when we got there. Come to find out, the airlines lost our luggage. That was not a good day. Then the cab dropped us off on the wrong street. Then we finally find our Airbnb, and what do you know? There's a note on the door. "Sorry, on vacation, the key's under the mat." So we were confused at what to do next. We were scared. We were in a foreign country with my grandmother. Actually, we brought my 8-year-old niece with us too, so that was quite the party. But none of us spoke French. Grandma's French was way back when she was a kid. And we didn't have Google Translate, so we didn't know what to do. We felt lost and vulnerable. Our patients feel like this. Hospitals are like a foreign country. They don't know the language we speak. They don't know our systems. They don't even know sometimes who's taking care of them or who to ask questions. So these warning signs that our patients and families can share with us are really truly like the red flags on the beach, right? I'm in pain. I'm worried. I'm afraid. These can be threaded into the EMR or EHR system, where when these combination of words, and then we look at the data too, and it can flag that we really need to take some action and do something. So this is a family member, Sophie. who used the cuss words and used the QR code. Her brother Travis, living the dream. He's the 22-year-old star quarterback of his football team, and he's dating the head cheerleader. Until the last game of the season, when he's tackled pretty rough, breaks a couple ribs, breaks his femur, and now he's laying in his hospital bed recovering. When his sister, Sophie, she'd given their parents a break to go home and get some rest, said, he doesn't look right. He's pale, and his breathing is shallow and labored. And she thought something was wrong. So when the nurse came in the room making her rounds, Sophie said, hey, I think something's wrong with my brother. Well, the nurse, busy as we know they are, said, that's kind of normal for somebody who's just had surgery. So I'll come back in a little bit. Well, Sophie wasn't okay with that answer. She still felt something was wrong, and she didn't feel like that was any kind of resolution for her. So she got the QR code and texted, somebody please help, I'm scared. So this rang to the charge nurse alert, who came in the room, looked at Travis and said, oh my gosh, I think you're right. Called a rapid response, called the surgeon, and got Travis into surgery to repair the bleed that they found, the internal bleed. That's the way it should happen. So respond with urgency. We know time is critical in healthcare. Seconds sometimes and minutes can make a difference. Helen talked about this too. We didn't plan this, but we should have. Failure to rescue. I didn't know this was the thing until I started my master's degree back in 2009. I'd already been a nurse for 30 years. How did I not know this? We don't teach it in the curriculum, probably not medical school either. But it is so critical because, again, if we don't recognize those signs and symptoms and use that clinical judgment to create this potential, we need to act right now because something is going on. It's those early signs, and they do happen, the literature tells us, 6 to 24 hours before an unplanned cardiac arrest. Do you guys think that's time to respond? 6 to 24 hours that make a difference? So this is Mr. Ramirez, 77-year-old that was admitted from a nursing home with new onset confusion and a suspected urinary tract infection. Now, we know infections in these vulnerable populations can easily and quickly turn into sepsis. But with predictive analytics that were plugged into his EMR system with just a software, didn't have to redo anything vital or critical, predicted that he was a sepsis risk when it flagged his increased heart rate, his decreased oxygen saturation, his falling blood pressure, and his increased white blood cell count. So that alert triggered the team who went in and assessed and said, yes, we've got a problem here. They started the sepsis protocol, and Mr. Ramirez survived. So I'm not saying AI and technology is replacing us as human beings, but it gives us the opportunity to see these early predictors and group them together instead of sometimes just a shift change, which might be hours later. So that's the beauty of what we can be able to do with technology and with AI. Ensure the loop is closed. So this is an essential piece of what I want to talk about too, because it's one thing to respond and have the tools for the patients, but if we don't close the loop, we haven't done our job completely. So this is Mrs. Jackson. She had hip surgery, was complaining of being uncomfortable when her daughter said, Mom, are you sure you're okay? Because she had just had her pain medication 2 hours earlier. She wasn't due quite yet. She goes, I'll be okay. I just feel uncomfortable and I can't get comfortable. So Mrs. Jackson's daughter picked up the bedside tablet and wrote, my mom's pain is not manageable. The charge nurse came in when she got the alert, came in and checked her and had a conversation with her, picked up the phone and called the surgeon and got her medications adjusted. So the next morning, the patient experience team came in and asked her, "How are you doing now? Is your pain better?" "Yes. Thank you so much for listening." It not only helps the patient experience, but these tools that we have really improve the frontline morale too. When they can see in real time the changes that they've implemented and what they've done, we hear things like that in the team huddles. "I really feel like I mattered today. I really feel like what I did was important." So when we talk about how are we going to implement this into our workflows, and I would suggest thinking about this when you go back to your workplaces, but there's several steps we must do just because it's how we implement anything to change culture. So I'm not going to go deep into all of these. I definitely will give you the slides as the others have. Establish ownership. Whose responsibility? We have to have metrics that we measure. We have to have a structured review process when we do get those. And I know others have talked about this today too. We have to have a formal response, feedback response. We have to train and give our teams resources and promote transparency. That is so key with our patients. Really, to build that bridge of trust requires us to be transparent. We need to be partners with our patients and their families because, as we said earlier, communication breakdowns, it's not just between healthcare providers and it's not just between the patients and the family, but it's the whole care team, which includes the patient who is central. So the results have been phenomenal. Patient safety indicators, less incidents of failure to rescue or patient harm events, HCAP scores increasing, staff morale, and patient trust. Would you say that's a win-win? Yeah, we all want that, right? So this slide, if I want you to look, we've got the 4 care areas that we know we get reimbursed on by Medicare through those 4 domains, the HCAHPS, the efficiency and cost reduction, safety, and clinical outcomes. Well, I want to propose implementing the care framework actually increases and improves all of these. I don't know if you guys are aware of this, but several years ago, there was a study. Hospitals on average spend 13 to 15% of their annual operating income on patient harm. That's a lot of money, right? Not only is the patient and their family impacted, but the bottom line is too. And if we look at this one, this is just a model of a hospital that is a $10 million revenue from Medicare, eligible for that, and that each 1% is $100,000. So if we look here at the HCAP scores on the bottom, and we look at the CMS adjustment here, and we look at the dollars here, negative 200,000, negative 100,000. But if we make this adjustment, you can see clear up to the top here, we're getting reimbursed and not penalized. I think that's pretty significant, especially in today's world that we're living in with the uncertainty. So again, just the care framework. I think it's so essential that each part of these, we indicate to our teams as leaders that this is important to us and that we hope that it will be important to them. Because I believe when we build those bridges between our patients and the family, and we put the heart back in healthcare, there should be no patient that dies because we failed to listen. Thank you. Questions?
Great storytelling, Dr. Julie. And she's very right. A lot of responsibility falls on all of us, whether we're patient facing or not. Do we have any questions, comments for Dr. Julie? Any closing remarks? Let's hear one back here.
So the real question I have is about discernment. So how much value do you place upon that of the medical provider and how much do you place upon the family because sometimes the family may be over concerned and it may be a natural response. They've been worrying about them all day long. So that seems to be a difficult line to tread.
You're right. When patients and families are concerned, sometimes it is nothing, but it always is our responsibility as healthcare providers to go in and check and reassure them, but not to blow them off. And I think there's a big difference in how we say, like the nurse with Travis and Sophie, oh, he'll be fine. And he wasn't, is really listening. I know it takes an extra minute, but a lot of times they're really concerned and overreactive, we say sometimes, because they're scared. Again, that fear word, right? That snake on the head. But I think that those little signs also, we as healthcare providers need to tune in because those family members know that patient way better than we do. As Helen said, we're in the room as healthcare providers and out and in and out and don't even have the same patient on the same day a lot of times. But the families know. And so when a wife says he's not himself, even if it's something we can't capture in the data yet, just like with Mr. Thompson in the first story, his wife knew something. And if we'd been tuned in and watched the small deteriorations that combined together add up, then that's when we can make the difference.